In this lecture, we will discuss the components of activity and exercise in Chapter 39 from Potter and Perry. Throughout this lecture, we will discuss the regulations and factors that affect movement. We will also review the concept of activity through the lens of the nursing process. Remember, the nursing process consists of assessment, diagnosis, planning, implementation, and evaluation. In addition, we will also address the key terms relevant to activity and exercise. Regular activity directly contributes to a patient's physical and emotional well-being. Nurses must be aware that deconditioning and functional decline can affect all our patients. However, hospitalized patients are at greatest risk for inactivity. This can be from a relative or actual restriction. For example, some patients choose to not get out of bed, whereas other patients have a physician order that restricts their movement. Take a minute to think about what patients should be restricted to bed. By adhering to the concepts of alignment and balance, we can facilitate body movements without causing injury. For example, when a patient gets out of bed, are they standing tall with their shoulders back, or are they slouched looking at the ground? Friction can occur when you're moving a patient up in bed. To reduce friction, we might also ask our patient to bend their knees and push up with their feet as we lift them. When appropriate, patients might be given an exercise plan to facilitate their recovery. This plan will consist of isotonic and isometric exercises and are typically developed by a physical or occupational therapist. Examples of isotonic exercise include walking or swimming. A common isometric exercise might be gluteal contractions. This picture is an example of an upper body isometric exercise. Isometric exercises are great because they're effective for any fitness level or age. They're easy, convenient, and impose less risk. I want you to have a basic understanding of these terms. You should be familiar with the structures and functions that regulate movement. However, remember that your priority as a nurse is to identify what patients are at risk for decreased movement secondary to impairments of the skeletal, muscular, and/or nervous system. For example, does your patient have osteoarthritis of the knee or hip? Does your patient have advanced multiple sclerosis or muscular dystrophy? Did they suffer a stroke that left them partially paralyzed? Patients that are younger or in middle adulthood are more active and tend to have correct posture and body alignment. They look and they feel good. In this age group, a pregnant woman would have the altered sense of gravity. As a result, they may suffer from back pain or be at risk for falls. So what would we do for this patient? Would we discuss safety measures to avoid falls? We might instruct the patient not to reach for items on a high shelf, avoid climbing on stools or chairs, and wear shoes that don't have a heel. As people age, they tend to lose muscle mass and bone density. These changes occur from inactivity or hormonal imbalances. As a result, these patients are at risk for osteoporosis and a loss of posture and body alignment. What can happen to these patients? What would we do for these patients? In an effort to encourage safe physical activity, we have to first identify what patients are at risk for inactivity. From there, we can identify their willingness to learn, educate them on safe physical activities, and reinforce this education. Increasing activity is not only about recovery, but disease and illness prevention as well. Factors that might influence activity tolerance are listed on this slide. For example, does a patient suffer from arthritis? How about hypothyroidism? Those patients have a low metabolism rate. They may not want to get out of bed. Patients with decreased cardiac function may have advanced heart failure, and their heart may not compensate for that increased activity. What about pain, whether it's acute or chronic? That may live in activity. Patients who suffer from pneumonia, one of the key manifestations of pneumonia is weakness that lasts for months, even after the illness is over. Anxiety and depression. Typically, these patients lack motivation and desire. This slide represents the subjective information we would collect from our patient regarding activity and exercise. What can the patient tell us? For example, with exercise, do they have any pain? Do they have any shortness of breath or discomfort with exercise? Maybe they have pain in their hip or in their knee with any type of walking or running. Does this mean that they might have some bursitis or tendonitis in their hip or in their knee? To assess a patient's ability to engage in activity, you should evaluate their ability to stand. Their head should be erect, body midline, spine straight, feet flat, and there should be a midline center of gravity. If not, this could increase their risk of fall and energy expenditure. To assess a patient's ability to engage in activity, you should also evaluate how they sit in a chair. Their neck and spine should be aligned, body weight evenly distributed, feet flat on the floor, and arms supported. This style of sitting can prevent musculoskeletal injuries. Also, if you have a patient who is weak, this position in the chair may prevent them from sliding out or developing a pressure ulcer. This slide is a perfect example of how a person should be sitting in a chair. If a patient is lying in bed or unable to get out of bed, assess them in a lateral or side-lying position. Conditions such as traction, unilateral weakness, or a spinal cord injury might restrict a patient to bed. You need to make sure their spine and extremities are aligned. There should not be too much flexion or extension on the neck. When assessing a patient's mobility, you need to look carefully at their range of motion and their gait. Can they participate in an exercise plan or complete their ADLs or IADLs? Do they have limitations in their range of motion? Is their gait smooth and even paced? Do they have a limp or swing their leg when they walk? We must also assess their tolerance to activity. This can be measured by collecting subjective and objective data before and after activity. Did their vital signs change with activity? Is there a change in skin color with activity? How does the patient feel? Our highest priority nursing diagnoses with activity and exercise are impaired physical mobility and activity intolerance. Remember, our risk diagnoses are less important than our actual diagnoses. Our goal is to improve or maintain motor function or to improve activity and tolerance. Your outcome might be to perform 20 minutes of exercise 2 times a week over the next 2 weeks. The nursing interventions that would be utilized are independent and collaborative. Collaborative secondary to working with physical and occupational therapy. Positive effects of exercise. Regular exercise can strengthen the cardiac muscle and its contractions. It can also improve lung ventilation and capacity. Exercise can increase our metabolic rate and enhance the ability of our cells to utilize glucose. It can also increase muscle and bone mass, decreasing our risks for falls and fractures. It also can improve the outlook on life and enhance a patient's immune system. A patient must have the physician's permission to participate in an exercise plan, or even to get out of bed if they've been restricted to bed. Together they can decide what the overall goal of the plan is. Patients should participate in physical activity 3 to 5 times a week for 30 minutes. The exercise plan should be a combination of aerobic activity, stretching, and resistance training. Simple activities like walking or raking leaves might suffice. If a patient is in the hospital, you might encourage them to walk up and down the halls twice a day, or sit in a chair for all meals. Body mechanics. Proper body mechanics decreases back injuries in not only our patients, but in our healthcare staff. It's very important for the nurse to use proper body mechanics when assisting patients with exercise. Always make sure you use your center of gravity and bend at the knees and not bend at the waist. Always ensure you have adequate help when lifting. And don't place your patients or you at any additional risk. This is a slide that just shows how appropriately to get a patient back into a wheelchair. In order to mobilize joints and prevent contractures, we can encourage our patients to participate in active range of motion. If patients are unresponsive or paralyzed, we can implement passive range of motion. This is a slide that depicts several range of motion exercises. For the hospitalized patient, before we help our patients ambulate, we must assess their ability to do so. Have they been out of bed before? Do they transfer or ambulate with one or two people? What kind of assisted device do they use? Always make sure the patient has slip-resistant socks on prior to getting them out of bed. Getting patients out of bed, you need to help patient to a sitting position, and you always need to dangle the legs a couple minutes, either 1 to 2 minutes on the side of the bed. Quickly, you may monitor for orthostatic hypotension. This is when you get a patient out of bed and their blood pressure will drop. Signs and symptoms of this, obviously, is their blood pressure will drop. They may be lightheaded, dizzy, they may get pale, diaphoretic. We always need to provide support at the waist to keep the center of gravity at midline with a gait belt and walk the patient with a gait belt. If the patient starts to fall, we can use a controlled fall method if the patient becomes unsafe. If a patient starts to fall, we should proactively lower them to the floor. You should stand with your feet apart, extend one leg and let the patient slide against your leg to the floor. Bend your knees and lower your body as the patient slides to the ground. The two most common assistive devices are walkers and canes. There is a standard and there is a rolling walker. Walkers can provide stability and balance. Patients must be able to lift the walker. Rolling walkers are great for patients who want to move quickly, but they can also pull the patient forward. There are straight and quad canes. Canes provide less support than a walker, so typically they are a step down from a walker. Always make sure to keep the cane on the strong or the unaffected side of the body. The cane goes 6 to 10 inches forward. Keep weight on both legs, and the weaker leg goes forward with the cane for support. These are just two pictures of a standard walker and a quad cane. Assistive devices crutches, either wooden or metal, they're adjustable and they're temporary. These should be individualized to the patient. Typical injuries include sports or a fracture. They may use crutches. Make sure that your patients don't lean on the crutches and support their weight, as this can cause injury to the axilla nerve. Always make sure to keep the tips on the crutches dry to avoid patients slipping, and we should always assess for breaks or cracks in the crutches to prevent injuries. Always teach the patient to have an extra pair of crutches available. Like we said, crutches are measured to the individual, so you shouldn't share them. When you measure them, they should be measured from the height, angle of elbow, and the distance of the crutch pad to the axilla. There are 3 kinds of gaits that are discussed in your book of how to walk with crutches. Essentially, the definition is the alternation of the pressure on legs with the crutches. So there are 3 types of gaits that are talked about in your book: a 2, a 3, and a 4-point gait. Crutches should be 3 finger widths from the axilla to the crutch pad. The pad should be 2 inches lateral and 4 to 6 inches anterior to the front of the patient's shoes. From the hand grips, elbows should be at a 25 to 30 degree angle. A crutch stance forms a tripod position. Crutches should be placed 6 inches in front and 6 inches to the side of each foot. Walking with a crutch requires a 2, 3, or 4-point crutch gait. I listed 3 short videos under the media section for week 2. The videos demonstrate these gaits. 4-point is where each leg moves alternately with each opposing crutch. This gait requires weight bearing on both legs. A 3-point gait is where weight is bared on the unaffected leg and crutches, but never on the affected leg. A 2-point is where a patient moves a crutch at the same time as the opposing leg, so the crutch movements are similar to arm motion during normal walking. Lastly, evaluation. If your goal is met, you can discontinue the plan of care. Questions you might ask are, how well did you do walking? And how did you feel walking?